medicine with emphasis upon shoulder and knee. So today, shoulder and rotator cuff, the presentation will be start with anatomy and function of the rotator cuff, just to provide a little bit of background in order to support the rest of the talk. And then we'll talk about shoulder symptoms, exam findings, and especially with Dr. Polstra here, who will talk about cervical spine, we'll be differentiating what is rotator cuff pain, what is a shoulder problem, and then what is a neck pain or a cervical spine problem. So starting with the anatomy, very briefly, shoulder is two primary joints, the acromioclavicular joint and the glenohumeral joint. The glenohumeral joint is the ball and socket, and the acromioclavicular joint is the collarbone where it attaches on top of your shoulder to a portion of the scapula. And the scapula also is considered a joint as it articulates with the chest wall. And here are rotator cuff muscles, four primary muscles. On the top is the supraspinatus. You can see that in the picture on the right here, the top and here. In the back is the infraspinatus. Teres minor also in the back, and the front subscapularis. And these muscle and tendon units help to rotate the ball in the socket, which effectively helps us put our hand in space where we need to use it. A deltoid is the big muscle that covers the shoulder. That's the one that when you look at somebody, that's what you'll primarily see on the outside of their shoulder. One of the important ways that the rotator cuff works, in addition to acting as a system of pulleys, it helps to compress the ball into the socket. Think of a series of pulleys, a pulley on the top of the ball and socket, a pulley behind, and a pulley in front. And if these are all moving in synchrony, that will help you rotate the shoulder and lift the shoulder against the fulcrum, which is going to be the socket. Another part of the anatomy is the acromion, three types of acromion. Type 1 is flat. This is the bone on the very top of your shoulder, and it's important in terms of impingement of the rotator cuff by this bone. Type 2 acromion is a little bit of a curve, and here we're looking into the socket from the outside of the shoulder. Type 3 has more of a hook on the outside. So again, you can see the acromion and its position with respect to the rotator cuff, particularly the supraspinatus muscle and tendon. So rotator cuff disease, far left, you can see a rotator cuff tendon that's frayed. It's still able to work, it's still connected. This may be a painful condition. And then a hole sometimes develops, a tear in the rotator cuff. This is a small tear, and the tear tends to enlarge over time. Think of a tear in your clothing. It'll stay the same or grow bigger, without attention. And this tear in picture number 2 is a supraspinatus tendon tear. The supraspinatus tendon here should actually attach here. So it's tearing and pulling back. This is a tool that's actually in the tear. This is a surgical picture. And now imagine that the tear has extended from the supraspinatus here back into the infraspinatus here, growing larger. This is the ball and socket. And then here in the last case, the tear is very chronic, very retracted. And here's the socket, here's the ball. The ball essentially is uncovered, and which makes it difficult for the ball to be compressed into the socket and allow your shoulder to function. So again, schematically, looking at the diagram here, look again at the supraspinatus muscle tendon unit on the top, and then the back and the front, pulling the ball into the socket. If we lose that force, that array of forces, then the ball may escape and actually ride up underneath and touch the bone on top, the acromion bone. So again, here's the ball, the socket, and the acromion bone. This particular radiograph shows a shoulder with advanced osteoarthritis, both at the acromion and at the ball and socket joint, the humeral head and the glenoid. Here's an example, again, schematically showing a rotator cuff tear on the top and then the ball escaping up once the forces aren't able to depress the ball anymore. So associated problems, we just saw the acromioclavicular joint and arthritis at that joint. Again, that's the collarbone, the bone on top of your shoulder that connects with the acromion. And biceps tendon, we've seen the biceps tendon in these slides as well. One portion of the biceps actually passes from your biceps, the muscle in front of your arm, and what's called the long head passes up underneath the rotator cuff, actually into the joint. There's another portion of the biceps, the short head, and biceps has two heads, hence the name biceps, and that attaches more in the front. It doesn't go over this pulley. The picture on the bottom, again, shows the clavicle and the acromion, the acromioclavicular joint, the AC joint. In this particular radiograph shows pretty significant narrowing with a spur on the top. This is advanced arthritis in the acromioclavicular joint. Again, a close-up, focused view of the biceps. And I want to show this slide because it shows how the biceps tendon comes up and over a pulley system and then attaches inside the joint. People sometimes have pain in the biceps where it crosses this pulley. It moves back and forth as your arm flexes and extends, and the wear in this groove sometimes becomes a painful condition. So where do people feel pain? When they come to the office or when you're at home and you're trying to decide, what's wrong with my shoulder? Where are typical areas of pain? Often in rotator cuff pathology, the pain will be actually felt on the outside of the shoulder, over the deltoid, here and here. Often pain radiates down the arm, the outer part of the arm, and people frequently have a complaint of a tight, tender upper trapezius, which is the muscle between the shoulder and your neck on the top of the shoulder. All these are related, can be related to shoulder dysfunction, and they can be related to neck or cervical spine issues as well. So common shoulder presentation, pain in the deltoid, that area we just looked at. Pain may be described in a variety of ways: sharp, dull, aching, throbbing. Overhead activity, so reaching your shoulder up, which often may pinch the rotator cuff under the bone on top of the shoulder, the acromion bone, may be painful. Stiffness and neck pain, that's an area where shoulder pain and neck pain or cervical spine symptoms overlap. But think back to the upper trapezius. That often is tight and tender, And if because of the size of this muscle and its attachment from the shoulder all the way to the neck, you could feel like you have top of the shoulder pain or stiff neck pain. All right. Shoulder and rotator cuff pain usually is not associated with pain, numbness, tingling, extending below or beyond the elbow, particularly into the hand. That's more of a cervical spine issue, which Dr. Polstra will be covering shortly. All right, normal range of motion. This is a shoulder physical examination. Forward flexion, how far can you reach up? Typically, almost all the way up. 180 degrees is reaching straight up, so nearly reaching straight up. Abduction is reaching to the side, and if you bring your arm to the side and up overhead, usually, people can get to about 170 degrees, again, almost straight up in the air. Scaption, we think of that as motion aligned with the scapula, which is between, this motion is between flexion and abduction. And again, in this case, reaching up, a healthy shoulder often reaches 170 degrees. With your arm at your side, think of external rotation as moving your hand away from the front of your body with your elbow tucked against your side. 60 degrees is a good motion there. And internal rotation, reaching back behind your back to T10, which is a little bit above the lumbar spine and just reaching up into where your ribs attach to your spine. Okay, getting back to the normal anatomy, we've covered this with rotator cuff muscles, the biceps, the two tendons of the biceps. Any of these areas can be tender, and the tenderness is a part of the exam, which helps us determine what is happening with a sore shoulder. So some tests that you may see or hear, or if you're at the doctor, they may do these tests. An impingement test is reaching up above shoulder level, and the pinching of the rotator cuff under the acromion bone often can cause discomfort. And this discomfort is felt along the deltoid, along the outer portion of your shoulder. A Hawkins impingement test, it occurs when your arm is flexed forward and then your hand is rotated up and down so that the ball and the rotator cuff pass under the acromion bone. Another type of impingement test. Two tests that are very specific for the biceps are called Speeds and O'Brien's tests. And they're with your arm facing palm up and palm down in front of your body, and see if discomfort occurs with resistance. In that position, cross-arm test is moving your arm across the front of your torso, which tends to pinch the acromioclavicular joint, the end of the clavicle, and the acromion bone. Testing for specific rotator cuff strength occurs when we push against the rotator cuff tendon in the plane that it's pulling. So for example, supraspinatus, the tendon on the top, the doctor may want to push your arm down to see the resistance strength. The infraspinatus is in the back, so we'll tend to pull your arm in external rotation or pull your hand out to the side. Subscapularis is the big muscle and tendon in the front, and tests such as pushing into your belly, reaching across your body, putting your palm on the opposite shoulder and trying to hold it there are typical tests for subscapularis. So differentiating neck pain and shoulder pain. And again, Dr. Polstra will get into this. And these two areas are very related. Neck pain, often located in the neck or the upper trapezius, the big muscle on top of the shoulder. It can involve the deltoid, but deltoid, again, is more of a shoulder and rotator cuff issue. Neck pain or cervical spine issues, pinched nerves in the neck will tend to radiate past the elbow, whereas rotator cuff issues and rotator cuff pathology will tend not to cause symptoms past the elbow. Night pain typically doesn't happen with neck or cervical spine issues. Possibly laying on your pillow or positioning at night can exacerbate this. Neck pain often results in a stiff neck, and neck pain is increased with motions and resistance that are performed during a neck exam. Imaging findings are always important. X-rays and then MRI will offer a combination of imaging that will help greatly in determining what is the cause of your neck or shoulder pain. And again, being a little bit repetitive, cuff issues, they tend to radiate toward the deltoid or in the front of the shoulder toward the biceps. Upper trapezius, big on top of the shoulder, is an area of overlap between neck and shoulder issues. Pain symptoms along the outer part of the arm, but not past the elbow, are more typical of a rotator cuff. Night pain from laying on your side happens more often with a rotator cuff issue than we find with neck and cervical spine issues. Stiff shoulder rather than stiff neck. Overhead motion reaching up, out, and behind tend to be related to shoulder and rotator cuff issues. And exam findings, the test that we just went over, as well as radiographs and MRI, are very helpful in determining rotator cuff issues. So how does one injure a rotator cuff? Acute injuries, and acute injuries are less common than chronic overtime injuries, but the acute injuries may occur from a fall. A very typical way to injure your rotator cuff is diving, landing on outstretched hand. This forces your arm up and forces the rotator cuff up into the acromion. These can be large tears, and they can progress fairly rapidly if they're complete and multiple tendon tears. Chronic rotator cuff tears are much more common. There are statistics which indicate that a 60-year-old, maybe 28% of the 60-year-old age group have asymptomatic rotator cuff tears, and up to 50% of 80-year-old people may have rotator cuff tears, period. Typically, these tears are not symptomatic. The tears tend to stay the same again or increase in size, similar to a tear in your clothing. When size increases, the tear tends to retract. Think of elasticity of the muscle tendon unit, and if the rotator cuff is no longer connected to the bone, it will tend to pull back, similar to a rubber band. Progression occurs typically over a longer period of time, and a progression may occur to rotator cuff arthropathy. And again, think back to the slide earlier, which showed that the ball, the humeral head, had actually escaped from containment within the rotator cuff and was now pushing against the acromion. Acute on chronic tears, and think of a tear that's pre-existing or a partial tear and an acute injury occurs. This definitely can happen with lower end energy trauma. And again, the chronic rotator cuff pathology has a long-standing history, can worsen gradually over time. This is one of the reasons that people can have asymptomatic tears. If the tear occurs very, very gradually and over time, often a person is able to adapt and may not know that they have a rotator cuff issue. So diagnosis, again, shoulder pain, shoulder weakness. A rotator cuff functions to position your hand, to move your arm, and weakness compared to what is typical for a person is an indicator that there is a rotator cuff issue. An acute shoulder injury can be indicative of a rotator cuff or biceps issue. Radiographic changes, and then an MRI is very important because the MRI actually can see and show the different tendons of the rotator cuff. Treatment, if you have had an acute injury, rest, which is often the common sense treatment, modify activities below the level of pain, Tylenol, non-steroidal medications such as Advil, Aleve, taken only if you do not have stomach issues or kidney issues, and taken with food. Physical therapy can be helpful in the early stages to try to restore function of the shoulder. Injections, these are only in very selective cases. Typically, a cortisone or a steroid shot is not done early, but this can be a good anti-inflammatory in the right situation, particularly if a patient does not have a tear existing in the rotator cuff. Cortisone should be used very judiciously. For example, not more than every 3 or 4 months and not more than 3 per year. A newer technology in the last decade that people are more and more interested in, platelet-rich plasma injections. This has promise in terms of the thought that injecting healing elements from the blood within a shoulder or any particular area should be helpful. However, at this point, there are no controlled science studies that show that this definitely works. And of course, with a rotator cuff tear, often surgery is necessary to repair the tear and allow someone to return to normal functional activity. Surgical treatment is shown here. On the left is an arthroscopic surgery. An arthroscopic camera is placed in the shoulder. The front of the shoulder actually is here. The back of the shoulder is here. Anchors have been placed in order to sew the rotator cuff tear together. Sutures attached to the anchors are seen actually coming out of the shoulder here and here. And then there's another way to repair shoulders, a mini open repair here. There's a small incision on the side or the front and the side of the shoulder. And again, here's the top or the front of the person. Here's the top of the shoulder. Here's the opening, and an anchor with the sutures is seen here. The anchor is placed in the acromion bone, which is part of the top of the humerus. Other surgical treatments for a painful AC joint, a distal clavicle resection, also known as a Mumford procedure. Sometimes we do that. Again, this is for a symptomatic acromioclavicular joint that has failed other treatment options. Recall the bone spurs seen as shown earlier in the talk. Sometimes, particularly a type 3 acromion, a spur that is symptomatic and has not responded to other treatment, may need to be smoothed. But again, these are unusual surgeries in isolation. Often they're accompanied by rotator cuff surgery. Further treatment of the biceps tendon and biceps pain is problematic. Tenotomy versus tenodesis. And a tenotomy is to simply release the biceps tendon to take pressure off of this tendon. Thankfully, when this happens, people usually have similar function. It doesn't require any additional incision when done at the time of rotator cuff surgery. Possible loss of bicep strength and possible Popeye deformity, meaning the biceps in front of your arm looks a little bit peaked. Sometimes people get cramping in the front of their arm with repetitive activity. And this is the injury that famously John Elway had and Brett Favre had, and both did very well in their throwing arm after having a detached long head biceps. Tenodesis refers to cutting and then reattaching the biceps tendon in a position that is less painful and in a position that is under less stress, requires additional surgery. There's less likelihood of having a Popeye deformity, but there is a possibility of pain at the surgical site because the biceps is actually anchored into the bone. So in summary, we've covered anatomy and function of the rotator cuff and the shoulder, presentation of rotator cuff issues, shoulder issues, including biceps and acromioclavicular joint. What are the symptoms? What to expect if you have an examination with your doctor, and an introduction to ways to differentiate what is shoulder pain and what is neck pain or cervical spine pain, as these two areas overlap, and then treatment options, some of the options that we use to treat the rotator cuff issues and help people restore their function. Thank you.
Thank you, Dr. Murray. We're going to move to Q&A session now. I do have a couple of questions to start with. First question is, do AC joint arthritis and torn rotator cuff often present similar symptomology? Can they only be differentiated with an MRI?
They can have symptoms which overlap. So the AC joint typically has symptoms at the AC joint and often is accompanied by rotator cuff issues as well. A good physical exam can help differentiate these two, but at the same time, MRI will be helpful in showing what is rotator cuff and what is AC joint. And again, radiographs, then an MRI, because radiographs are very helpful with the osteoarthritis.
Thank you, Dr. Murray. Next question. If the rotator cuff tear is minimal, or if the diagnosis is arthritis, do cortisone injections help?
You broke up a little bit. Could you repeat the question?
Yes, absolutely. If the rotator cuff tear is minimal, or if the diagnosis is arthritis, do cortisone injections help?
Cortisone can be helpful in terms of symptom relief. It's a strong anti-inflammatory. And in the face of arthritis, I would be more likely to consider this, again, to keep someone functional. If there even is a partial rotator cuff tear, I am hesitant to use a cortisone injection to keep someone functional because, again, repeated steroid in the shoulder can hasten the degeneration of the rotator cuff.
Thank you, Dr. Murray. Next question. Is there any preparation required for a PRP injection? Is your schedule open for PRP injections?
Oh, absolutely. Preparation, I'd like to have spoken with someone because there are a couple of rules that we have as far as preparing, what to do before and what to do after, but we're definitely open for PRP injections, and they are done in the office, same day during the time frame of a typical office appointment.
Thank you. The next question. Are there differences between arthroscopic and open rotator cuff repair?
The principles are the same. The basic principles are to anchor the torn tendon back to bone, and this may be done arthroscopically or it may be done open. The advantage of arthroscopy is that the incisions are smaller, although the recovery period and the rehabilitation is very similar. So in the end, it's a surgeon's preference, what they feel they do the best.
Okay, thank you. And the last question is, do I need to wear a sling after the surgery? If so, how long do I wear it and when can I take it off?
This is after rotator cuff surgery.
That's correct.
Typically, a sling is worn most of the time for between 3 and 6 weeks after. It depends on the repair, how large was the tear, the quality of the tissue that was repaired, and anticipating how long will this repair need to become stable and allow removal of the sling and beginning of physical therapy, for example.
Perfect. Thank you, Dr. Marie. Thank you for the presentation. It was very informative. I would like to ask you to stop sharing your screen at this time so Dr. Polstra can start sharing his.
All right, thank you.
Thank you. Welcome, Dr. Polstra.
All right, Leah, I think I'm on online now. Can you hear me?
Yes, we can hear you perfectly. Thank you for
Perfect.
joining us today.
Perfect. Thank you so much for having me. It was a wonderful talk by Kevin. I love how much I learned, actually. I thought it was incredible, and I love his calm demeanor while teaching us so many wonderful things. And as he alluded to, there are so many correlations between cervical spine disease, shoulder pain, neck pain, and vice versa. So I think this dovetails very nicely together. Shall I get started with this, Leah?
Yes, please go ahead.
Okay, very good. So thanks for joining us. You learned a lot already about shoulder pathology and heard Dr. Murray multiple times say the relation between the neck and the shoulder is a very close one. So we work collaboratively on a lot of you as patients with a combination of shoulder and neck pathology. And similar to his talk, we're going to go talk briefly about the anatomy and then the presentation of neck pathology, right? What do we see patients come into our clinic with? And maybe you can find yourself in some of these groups with what we call cervicalgia, which is neck pain. And then beyond neck pain, we will talk about radiculopathy and myelopathy. Radiculopathy means pain, weakness, numbness, tingling, and so on, that is along the direction of a nerve root. And myelopathy has to do with signs and symptoms of spinal cord compression. So those are things analogous to what was talked about before, right? You have arthritic conditions that can hurt your rotator cuff. In the neck, you have arthritic conditions that over time can hurt the space for the nerves coming out of the neck. So that's radiculopathy. It's a nerve root issue. And myelopathy has to do with the spinal cord that runs through the neck. And I'll have some images to share with you. We'll talk about imaging, what we do, and we'll talk about some treatment of cervical or neck pathology. And I want to stress that all of us here, we have 5 spine surgeons, are very much conservatively oriented. We know very well when to operate and which procedure to do, and I'll shine a little light on that. So we look at a cervical patient presentation. Typically with us, it might not be so arthritic as on the right-hand side there with all kinds of bone spurs, but typically the presentation of people that have this type of degeneration is neck pain or cervicalgia, with a difficult word. And then what we sometimes see, and I wanted to address this too, is people that come in at a much younger age with a very straight spine. And since this has to have a little bit of a link with sports also, we call this actually a spear-tacular spine. And folks familiar with football or other direct contact sports know that if you have a very straight spine like this, as opposed to a spine that has a bit of a curve called lordosis, that you are at a higher risk for an injury. And as you can see here, maybe where I move with my cursor, there was some load pushed on this gentleman's helmet, and the load didn't have a chance to dissipate through a bit of a curve in the neck because the neck was perfectly straight, and it led to absorption of the energy through a vertebral body here. So in this case, there is a vertebral body fracture, as you can see, because the normal spine here is depicted on the right-hand side with what we call lordosis, and especially in young people, that is important to be able to work sort of as a buffer, as a little spring when there is load placed onto the top of the head. But if you have a very straight spine and that load gets transferred through this area here, you're at a higher risk for having a fracture or potentially even having a dislocating event. What we see in football players too is that, you know, sometimes they get a hit from the side of the head, and then you have a traction type injury that can occur, as well as that on the opposite side where the neck is squeezed together, you can have a compression type injury, as you can imagine. So it's something that we see quite a bit, and this is again an interplay between the folks on the sideline, where Dr. Murray often helps. Is it a shoulder problem where my pain is, or is it coming out of the neck? So for that reason, I think it ties very well together that we look at this together with the shoulder folks. We talked about radiculopathy, right? Pain, numbness, tingling parallel to a nerve root going into the shoulder and arm. And then sometimes we see people with myelopathy, which is a little bit more rare. And often it's a combination of things. And it's for us to figure out what the patient actually has and what we need to help them with. Now, you heard earlier already the pain spectrum that comes from arthritic conditions of the shoulder, rotator cuff pathology. And as you can see here in the diagram, there's a lot of areas here where we speak about referred pain that comes out of the neck. So this is not a radicular problem. It's not a true nerve root transfer of pain into the neck and shoulder area, but it's referred pain from usually facet disease. Those are little joints in the neck, from arthritis that goes to the neck and is often confused with maybe trapezius pain, rotator cuff pain, and so on, because you can see exactly here where from different levels in the neck the pain would be felt onto the body. The good news is if people have this and they don't have strict compressive pathology, meaning the nerve roots are not tightly squeezed, there's a very high chance of about 80% that this resolves. And even with moderate or severe discomfort early on, more than a third of the patients get better on their own. So again, I wanted to drive the point home that we're mostly thinking conservative as opposed to operative. And occasionally you might have a little flare up with some improvement over time. But generally speaking, all of this can be managed conservatively. Now, when we start to get a little bit more into the mechanical reasons why people hurt and have this thing called radiculopathy, it is a nerve root compression issue. And as you can see here on the image, so these are little slices, transections, where you can see the nerve roots coming out of the spinal cord here, the sort of cream colored thing in the middle. And you can see a nerve root going out here that is squeezed a little bit, but the opposite side is even worse. And sometimes people have over time developed some degeneration and then have a soft disc herniation on top of it. So you play a bunch of pickleball and you looked up and suddenly there was a radiating, shooting pain, like a lightning bolt going through the shoulder down to the arm. It might actually be a superimposed disc herniation on some arthritis that you had already. And especially if it squeezes here in this part, where the nerve is trying to get through the nerve tunnel out of the spinal cord, it can give people a tremendous amount of initial pain. Usually, again, associated with degenerative disease, some arthritis of what we call the uncovertebral joints. Those are the joints right next to where the nerve roots run, and then some bone spurs that come off of the facet joints, the little joints that keep your spine aligned. Sometimes we have more than one level. That's not uncommon, especially if it's not a acute disc herniation, but if it has to do with arthritis that slowly closes nerve tunnels. As you can see here with my cursor, this is a squeezed nerve tunnel from the back due to some arthritis of the joint, as opposed to a normal nerve tunnel above. And it can lead to weakness, tingling in the arm, all the way sometimes to the hand, but predominantly, like Dr. Murray alluded to, beyond the elbow. It doesn't just stay in the shoulder. And you can have some sensory loss and sometimes a feeling that you can't like touch everything exactly as you can do on the opposite side. We can stress patients when they come into clinic, and we actually squeeze their head one way or the other very gently. And you can imagine if things were a little bit tight already, like you can see the right upper corner, and we put a little bit more compressive force on this, it is actually a sign that indeed a nerve root is in trouble when you start to feel numbness and tingling going down to your hand. For our boards, we have to learn very specifically which distribution the various nerve roots go to. So if we look at the levels in the neck, you have 7 vertebral body levels and 8 nerve roots that are coming out actually. If we look at the top and we have this sort of scapular pain, lateral neck, shoulder pain, we typically think about the C4 nerve root. If we look at deltoid discomfort, and Dr. Murray always looks at this also when he evaluates patients and tests the strength of the deltoid muscle, as well as that we look at biceps. How much can you sort of flex your arm up against resistance? That's usually the C5 or the C6 nerve root. And as soon as you start talking C6, C7, those are the levels where the neck transitions into the thoracic spine. We typically look at function in the forearm. We look at the wrist, how strong people can extend the wrist or flex the wrist forward. And we can tap out different reflexes to identify if there is weakness. If it's hard for you to push yourself away, you have triceps weakness, the muscle that runs on the back of your upper arm, then we typically think about C7, and the sensation actually goes very distinct to your middle finger. So if there's some numbness and tingling there. And if the hands give you progressive fatigue and it's very difficult to write, we typically look at a nerve, last nerve that comes out of the neck, as well as that we have to start thinking about things like carpal tunnel and peripheral nerve compression issues that can lead to similar symptoms. Now we go back to this radiculopathy and what causes it, right? There's multiple reasons that could be at bay here. So sometimes people have shoulder pathology that mimics a C5 radiculopathy that goes to the deltoid. And sometimes, as I said, there is these entrapment syndromes distal in the arm. And when we talk about carpal tunnel, most people sort of know that that's right at the wrist, and it can mimic a C6 radiculopathy from the C6 nerve root, as well as that cubital tunnel. That's sort of where your funny bone is. That's where the C7 and C8 nerve roots run through, and that can give you upon compression in the cubital tunnel, pain, weakness, numbness, tingling, those kinds of things to your pinky and your ring finger. And sometimes that mimics disease that comes out of the neck. And of course, we think with neck disease, we think about other things that have to do with the central nervous system, such as ALS or Lou Gehrig's disease, multiple sclerosis, and those kinds of things. So our detection light is always on. These things might be very rare, but it would be terrible if we missed those up on your presentation and then we'd sort of wave it off as radiculopathy. So please understand that we think always a lot beyond sort of the obvious, because sometimes interesting things appear. Now, if we shift gears a little bit then from radiculopathy to myelopathy, that has to do much less with the nerve roots, but it has to do with the spinal cord itself. And there's various things that we can identify on a patient that you might not even know, because typical myelopathy, like spinal cord compression, doesn't hurt. It doesn't give you radiating symptoms, but it gives you things that have to do with your coordination. And then the things that we test for are both in the upper and lower extremities, right? Because it doesn't have to do with a root that goes into your hand, but it has to go with the spinal cord that has roots eventually going into your arm, but also into your legs and your coordination of your whole body. So myelopathy is distinct spinal cord compression, which can happen through a disc herniation. And sometimes we see this very acute from a sporting injury, as you can see as the right upper corner. Sometimes violent trauma can be part of this, especially if the spinal cord was a little tight already and you had sort of these pre-existing issues, or if you're born with a slightly smaller spinal canal, just a small amount of arthritis or a small disc herniation suddenly can give you compression on your spinal cord. So sometimes people have congenital spinal canal stenosis. Congenital means from birth on. Spinal canal is the space that is depicted on the bottom here that the spinal cord lives in, as well as at the top here. And then stenosis means tightness. So you can imagine if your spinal cord was tight and then you suddenly have a pebble that gets squeezed out of a disc here between the bones that starts pushing on your spinal cord, you potentially get into a lot of trouble. So the contributing factors, this canal narrowing issue due to arthritis plays a role typically. If the space here, again, where the spinal cord is supposed to run, where this yellow arrow is not wide enough, then just a small amount of additional disc herniation material in that space can give you a lot of difficulty, as well as just repetitive trauma over time. Us as surgeons, looking down onto our surgical field are very much prone to this, right? Because we always sort of lean forward. So there's always a lot of additional stress onto the discs. And a lot of my colleagues, and hopefully I will never be one of them, but a lot of my colleagues have had neck surgeries because we over time develop, due to this repetitive trauma, some issues with our spinal cord. So what it's called is actually painless clumsiness. So it is a lack of coordination, much more so than pain, numbness, and tingling. And as you can see here, sort of vaguely on that right-sided picture, this was a patient who was seen with, some additional symptoms in the history with shoulder pain as well as some neck pain, and nobody really knew what was going on. And then we got the MRI scan. You can see sort of this hazy picture on the MRI scan of a very large process here that is compressing the spinal cord almost 50%, and it turned out to be an infection out of this area. So sometimes you see these red herrings, and you need to watch for those if they start to give patients these kinds of symptoms. So this painless process can also lead to a lot of wasting of hand muscles without it even hurting. So sometimes we see people with the picture on the right bottom there without significant pain, and they come in with difficulties in their hand, and they have wasting of their intrinsic hand muscles, like the small muscles that allow you for coordination in your hand. And sometimes we see this flattened, thinner muscle area. The thinner muscles, right, are sort of the stronger area at the base of your thumb, especially when you squeeze the tip of your thumb to your pinky. Both these muscles here, the thinner muscle and the hypothenar muscle, come up very strongly. And if you have a bad spinal cord, those muscles waste away. And then what you get is difficulties with manipulating small objects, opening jars, buttoning shirts, dropping things, and people develop balance problems, a sort of a shuffling gait. Again, some of these things have other diagnoses also, of course, at the origin of it. But if we find this combination of things and we look at patients and examine them, and especially do these tests that we talked about, right? You do a Hoffman's reflex. You can look this up on YouTube. There's beautiful videos of this, and it always is a little shaky when we send it over the WebEx. So I did not want to include it. But if you flick the middle finger, then the thumb is not supposed to twitch unless you have a spinal cord problem. So this is a very sensitive test. So we take the patient, and then when you come in, we flick your finger, and then we look specifically at the motion of the thumb. As well as that, we try to evoke something we call a clonus. So I would grab your foot and I would bring it up very quickly, and then we stretch the Achilles tendon because of that. And if you have spinal cord compression, your foot might actually jump 3 or 4 times in a row, as opposed to just a single one-time reflex. And it's called a clonus. And that is part of the whole gamut of symptoms you have from spinal cord compression. Similar if we bend the neck forward from the patient. So if you look sharply down to the ground and you have spinal cord compression, then some patients develop really sort of shocking pain and discomfort along their back, and sometimes upper and lower extremities are involved with that. So these are all symptoms that we can provoke by doing our exam and listening to you really well, that you might not have ever felt or have an understanding of what's going on with you if you develop this clumsiness and the gait difficulties and so on. What happens over time with this is that patients usually go through a prolonged stable period and then have intermittent worsening. And the problem is, if you have spinal cord compression and start to have symptoms, 75 to 90% of patients have this stepwise degenerative process that they simply get worse and worse and worse. And it's very rare for this process not to be progressive. So the problem is, if you don't feel what it is, but you feel yourself going downhill and don't really understand what's going on, it's up to us to figure out, you know what, this person needs an MRI of the neck because we're worried about the spinal cord, because it's a very insidious type onset, meaning it takes a while and you don't really understand what's happening and don't feel like a one day to the next pain signal going through your body. Complete reversal of this myelopathy is very rare, and most people need to have eventually an operation for it. So if they have findings and decreased spinal canal dimensions, if there's like no space for your spinal cord, this progressive degeneration is unavoidable, and we have to help you with that. The success of surgery for this depends on how long you've had symptoms and how aggressive the worsening is recently, as well as age. Sometimes we see this very aggressive in young people in their 40s, and they do fantastic with their recovery. If you're mid-80 and you've lost your ability to stand and walk, and your hands are very, very clumsy, and it turns out it's from the spinal cord, the likelihood to get better is rare, but at least we can prevent you from getting progressively worse and ending up in a wheelchair. Now, how do we do this? We get imaging studies, obviously. I don't want to belabor this too much, but we get side views, we get front to back views, we look at stability of the spine. And although this patient has a relatively well-preserved alignment, not infrequently do we get imaging studies such as this here, where you can see there is a tremendous malalignment of the spine. You can imagine having a spinal cord that snakes through here can give people a lot of difficulty because of compression at multiple areas. An MRI scan is typically very helpful to identify the spinal cord, to identify if there's any bizarre things going on with the discs. If there is plenty of spinal fluid depicted here in a light white color around the spinal cord that is gray here. And this is a normal picture. And to give you an idea, for somebody with myelopathy, meaning spinal cord compression, this is a patient from just 2 weeks ago. And you can see that there is a significant amount of compression around the spinal cord at all levels of the neck, both from the front as well as the back of the spinal canal. So if you do a comparison here, you can understand that a healthy spinal cord here has no ability to prevail in a neck like this, especially if there's still sort of snake-like motion around the spinal cord. What is important for you to understand is that there's a lot of patients that have some neck pain that might come in with an MRI scan, and then it turns out they have findings that actually are entirely normal. So it's important for us to distinguish people that have symptomatic findings versus just findings on the picture that are appropriate for their age. Similar to rotator cuff pathology, like Dr. Murray was talking about, disc degeneration in patients over 40 that are completely asymptomatic is approximately 60% present already. It's even 25% in people younger than 40. And other abnormal findings are narrowing of the nerve tunnels, disc herniations, disc bulging, and those patients might be entirely asymptomatic from that. So the purpose for us is not to just make the picture look pretty, but identify what's wrong with the picture associated with your symptoms, and then have a very targeted approach to your treatment. And what do? We typically divide you up when you come into clinic in 3 groups, right? There's patients with neck pain that typically can be managed very successfully non-operatively, as they have no instability, no deformity, no signs of nerve compression. And those things are usually self-limiting as time goes forward. If we look at nerve root problems or radiculopathy, we also try very much to stay away from an operation. And we typically are very successful with very little downside to weight, since the nerve roots can have a very long period of time before their symptoms are going to be permanent. Surgery is only necessary if there's unsatisfactory relief, or if you have a progressive deficit, like your bicep is wasting away, and from week to week, despite doing everything right with physical therapy and traction and so on, it is not getting any better. Then surgery is appropriately performed. And then if we look at myelopathy, again, the spinal cord issue, patients need to have an operation once you have symptomatic spinal cord compression, because we know the natural history doesn't look good. People get worse even if you don't do anything about it. So waiting has very significant disadvantages once you are identified to have myelopathy, meaning signs and symptoms of spinal cord compression. Now, the non-operative care is a variety of things. Discomfort can be treated with anti-inflammatory medications, sometimes some short immobilization. Traction is surprisingly helpful and can give people at least 80% chance of avoiding an operation if they did not have any signs of spinal cord compression, and if it's just a root compression. And sometimes we use injections somewhat sparingly, because again, you want to be careful with steroids, similar to what Dr. Murray said. So operative management for us is typically for patients with the myelopathy, if they progressively get worse, if they have so much pain that they typically can't tolerate the radiculopathy anymore, if patients have instability, and if they have deformity. Sometimes there is rare instances for deformity where we also need to do surgery. And what do we do then? We reconstruct you, right? In addition to the pressure of the nerves, we typically have to either fuse you, or we have to reconstruct things with a motion sparing device. And the hallmark procedure that we do is called an ACDF, described initially in the 50s, very successful after total knee and total hip replacements. ACDF surgery is the next most successful operation we do in all of orthopedic surgery. It stands for anterior cervical discectomy and fusion, meaning we take the disc out, we clean up the nerve tunnels, we take care of the compression on the spinal cord, we put a little block of bone or something in that space. Sometimes we use now a 3D printed titanium cage and a little plate, and the fusion rates to make this stable is very high, and the excellent clinical outcomes are noted there. People do well with this. Now, in that same space where the disc was removed, you also can place a disc replacement now. The results are very similar to the anterior cervical discectomy and fusion, but you don't fuse people, you keep them mobile. And there is, over time, more and more data now that this is a very good procedure. You can see one of the discs here with sort of a UFO type floaty in the middle. You can see another example up here. And this allows the spine to continue to move. So stresses to the adjacent segments, which we always knew were increased with a fusion, those stresses are potentially now dissipated through the disc, and the likelihood that you run into adjacent segment problems over time is less. Now, sometimes we also do very complex things, right? We talked about single, two-level problems here. I want you to know that all of us here are very comfortable doing very complex things. So more than two-level university type level care, we all perform here, and we certainly are happy to help you with this. And then sometimes we do complex, front back surgeries, take part of the spinal elements out, and then fuse people in a position like that. So just to give you an example real quick of a patient, you can see here and learn now from my talk, right, that the spinal cord on the left-hand side is badly compressed. If you take this image and make slices out of it, you get the pictures that you can see here. So the spinal cord is this gray thing here in the middle, compressed with a disc, as you can see with my cursor. The level below is even worse, where you have a large, broad-based bumper sort of pushing into the spinal cord. This is the CT scan with very little space here from front to back in the spinal canal. And what we then measure is this distance, and then we make decisions based on that, what the patient needs. You can imagine if this here on that cross section wasn't large enough, what we can do, we can enlarge the space to make it this big, as you can see here with a procedure that's not an ACDF or a disc replacement, but this is called a laminoplasty. So as you see a little bit of hardware in the back here. And what we actually do, we open up the space of that spinal canal where the spinal cord was badly compressed. And then we put a little piece of bone in here to keep this trap door sort of open, and eventually put two little screws in there to hold things in place. And then what the patient had moving wise beforehand and moving wise post-op from surgery while still having a perfect operation is basically the same. So this is typically for younger people with a well-preserved spine where we don't want to take all the discs out and do damage with a fusion, but we try to keep them mobile with a procedure, for example, like this. Now, as you all know, we are doing a lot of innovative things here. We're in Silicon Valley, so we try to use the power of the folks around us in technology to help us basically see with X-ray vision. So you see me working here in a lab, and I actually have headgear on that allows a direct projection of the spine onto my retina. So I look down onto the field, and with a variety of tools, we're able to visualize directly on my eyes the anatomy of the spine underneath the skin. So you can imagine that the process we're going through now is most predominantly diagnosis, making good treatment of you via solid principles, but we try to do this through progressively more advanced methods with less and less damage to you to get you quicker up and going, because we strongly believe that motion is lotion, we always say. So the less damage I have to do to get the surgery successfully accomplished, the quicker I can get you up and moving, and the faster you return to normal recovery and to work and play. And I'm very proud to be, not by myself doing this, but have a whole team of spine surgery within Ortho NorCal, Dr. Seago, Dr. Cannell, Dr. Gidvani, and then Dr. Ko. All five of us are very capable of dealing with all of your pathology, and would be happy to see you in clinic and help you with any and all questions you may have. So thank you very much for your attention, and we look forward to see you in clinic should that be necessary.
Thank you, Dr. Polstrom. Very informative presentation. I learned personally a lot as well. We are moving to Q&A session right now. I'll start with a couple of questions. Feel free to send your questions our way, and we'll respond to those as we go. The first question I have, is there an age limit for epidural injections?
Yeah, that's a good question. There's actually not so much an age limit, similar to what was alluded to before by Dr. Murray, right? We're careful with epidural steroids because they're typically not suited for you more than maybe 3 times a year or so, because there is some downside to it. The risks are very small, but you don't want to play with it, just every month or so. We sometimes say to patients with really bad pathology and maybe not the greatest health that repetitive injections 3-4 times a year is potentially the way to go to try to keep people out of the operating room. But I always say that if you have had 3 injections and they have not worked for you, well, then don't have the next 57, right? That doesn't make any sense. So I'm not a big believer in this pain management craze. For really old and sick people, potentially there's an option to maintain something with them. But if you have the ability to undergo an operation and you have had 3 shots that have failed and you have good surgical pathology, it's probably better to get it fixed than to continue with the steroids.
Perfect, thank you. The next question is for high school football players. Do you recommend including routine C-spine x-rays as part of the pre-participation physical to look for straight spine versus curved spine?
That's an interesting question. This has been brought up many times in the past, and it's a bit polarizing, right? Since we don't want to radiate people unnecessarily, because it's quite a bit of X-ray, and if you culminate that over the number of patients we would potentially see for the high school football clearance, the amount of radiation is enough that you potentially would cause cancer in 1 or 2 of those players. So I think the risk for doing that is relatively high, and it's probably better to go by symptoms through and look how much people can extend and flex their neck, because if you have a spiritacular spine, it is typically very difficult to bring it into full extension. So if people would be, say, completely asymptomatic and have a difficult time with extension, as well as maybe have had a stinger or so or something else that makes you a little bit more alert, then it might be good to send them on for a true evaluation. And again, even in my clinic with young people, we don't just jump to you go from the waiting room to X-ray before I see you. We typically evaluate patients first, and based on clinical symptoms, make the right decision what we should do with imaging.
Perfect, thank you. Next question. Can myelopathy cause brain symptoms?
Typically not. Myelopathy is a disease that stands on its own. I have seen people with really bad spinal cord narrowing that eventually had spinal fluid flow issues that led to some brain issues, but it's exceedingly rare. So it is typically independent from any kind of brain symptomatology. It's upper motor neurons, but it usually is not directly related.
Okay, the next question. Do you offer bracing services, and do neck braces help with the pain?
Yeah, so intermittent bracing can be very helpful. And we have full bracing capabilities here, but again, it stands with a good evaluation beforehand, and then we can decide if that's a good thing. The good news is with bracing to the spine, it doesn't have an atrophy, since the gravity is still working on the spine. So it is not like when you put a brace on your elbow and you take it off after 3 months that your muscles are atrophied. That doesn't happen with the spine so much, but you don't want it to be the only cane that you sort of stick with and hobble along on.
Okay, the next question. What are the main complications of the neck surgery, and how often do they occur?
As with any surgery, the main risk for anything is usually an infection. So the potential risk for a wound healing problem and an infection is probably 1 in 500 to 1 in 1,000 or so. So it's very, very rare. There is truly a theoretical risk only of paralysis and nerve root injury, because it's exceedingly rare for that to happen. And then the main thing is that as time progresses forward, we need to have, if you have a fusion, you need to have the bone fused together. So the likelihood for things to fuse is typically 95% and up or so. But as with everything, if you do enough, then you'll see a few people out of every 100 that might not have a solid fusion. And if that happens, usually after about a year, 18 months or so, after doing well, people suddenly start to become symptomatic again. So we have to do imaging studies and so on. And then sometimes we find out that the bone hasn't fully healed across, and which is not the end of the world, right? I mean, it's a fixable problem, and it's not so much a complication, but it's sort of a side effect of needing things to grow together. It's like a fracture that hasn't healed. Sometimes you need to have an additional operation to make that happen. But all in all, the patients that we operate on may have a little bit of a sore throat for the first few weeks after surgery, since the operation is mostly done from the front, if we talk about an ACDF. And all of that stuff is temporary and goes away. And as I said, it's a very successful operation, comparable to hip and knee replacements that get people up and going in no time.
Perfect. And the last question is, what should I expect during recovery from neck surgery?
If you had say a standard anterior cervical discectomy and fusion operation, you'll probably wear a brace intermittently for the first 2 weeks. It's not too restrictive, but it helps to sometimes reset your GPS a little bit, because sometimes people start to lean forward a little bit due to the arthritis. And when we reconstruct the neck, we bring you nice and upright. So then the brace helps you to remind you to keep your head upright. Intermittently for the first 2 weeks, as I said. After 2 weeks, the relatively firmer brace goes away. Depending on the number of levels, we sometimes leave people in a like a soft collar, again, more for the environment around you to make sure that they're careful with you. And you'll be up and around the day of surgery. Motion is lotion. We get people up every half hour, 45 minutes. Continue to do the same thing at home, and progressively you'll notice less and less discomfort in the neck from the surgery. You might have some swallowing issues initially that are easily managed by not eating a lot of doughy stuff. So don't go out for pizza on post-op day one, so to speak. Have some soups and some smoothies and those kinds of things as they go down easy. By 2 weeks, all of that stuff is gone. And then we just slowly but surely expand what you're doing. And if you're part of a SWAT team, for example, well, for 2 months, you are not able to participate with that kind of stuff. But if you have a normal desk job or so and can behave yourself, then within like a week or 2 weeks, you'll be back at work and certainly can do sedentary office work and so on. So it's not the end of the world.
Perfect. Thank you so much, Dr. Poelstra. We're going to wrap up, and I would like to thank everyone for joining us today. If you have any additional questions, please email us at marketing@orthonorcal.com or call our direct number, which is 408-412-8100. Again, thank you, and have a good rest of the day.
Thank you so much, Leah. Thanks everyone for your attention. Have a great rest of your week.